I think I'm really privileged tonight to have the chance to introduce my esteemed professors, those who I grew up learning from their expertise. One of them is definitely Prof Fahmy Saad. He's a professor in anesthesia, critical care, and pain medicine at Ain Shams University. He's actually an expert in obstetric anesthesia with more than 30 years experience in a major tertiary obstetric unit at Ain Shams University. So I'd like to welcome him. Please, guys, stay tuned. Listen to his very interesting lecture tonight about cardiac disease with pregnancy. And please, if you have any questions, pop them into the question and answer section of the Zoom program. I'm going to go mute and the podium.
I would like to welcome Professor Nasreen Rifai here. She is honoring us by her presence to be here, one of the chair of the session. And I'm so grateful for her time and her for presence. Thank you, Prof.
Thank you, Dr. Saad.
Thank you, Dr. Nasreen. Dr. Fahmy, the podium is yours. It's all yours, please.
Thank you, Mrs. Dr. Khulani. Thank you for Dr. Saad. Thank you for Dr. Nasreen, Mr. Sherman, for introducing me and introducing my lectures today. And I would like to thank the committee of MEGA Online for this very good chance to join a very valuable scientific meeting. Our issue today is the cardiac diseases with the pregnancy. As we know, the cardiac disease with pregnancy is the main cause, one of the main cause of peripartum cardiac mortality and morbidity. As the pregnancy places a normal heart under immense physical strains. If the heart is already compromised by an existing anomalies, it can result in a poor outcomes for both fetus and the mother. As we know, the onset of pregnancy makes a wide spread of physiological and anatomical changes that might occur during pregnancy. This physiological change may be a burden on the normal heart, can withstand this, but abnormal heart or diseased heart cannot withstand these abnormal events. The anatomical changes in the pregnancy, the increase in the heart size can be increased up to 30% if the heart appears enlarged in the X-ray. And the cardiac apex is deviated rightly to the left side with a left axis deviation approximately 15 grades. In the issue of the physiological changes of the pregnancy, there is a hemodynamic changes. These hemodynamic changes increase the pulse in the heart rate, stroke volume, and cardiac output in the first and second trimester by about 10 to 15 minutes, but increasing to the labor and delivery up to 20 to 30%. There is a decrease in the systemic vascular resistance with normal or slightly decrease in systolic and blood pressure. The cardiac output is when our concern is increased gradually up to the 50% during labor, and during contractions it may reach up to 75%. Each uterine contraction displaces about 30 to 50 ml of the blood into the maternal back to the excretion. This is what's called the autotransfusion. This increase in the stroke volume and heart rate and cardiac output increase approximately about 75% above the baseline. This magnitude must change. These changes will be influenced by the mode of delivery and the mode of anesthesia with the giver. We have to run to the basic management principles for the pregnant woman with the cardiovascular disorders. Any patients with the cardiovascular disorders have a risk assessment and management and treatment. Just before conception, pre-conceptional, we have to have a history of the cardiac disease or cardiac symptoms, arrhythmia, baseline exercise functional class, baseline ECG and echo with the left ventricular functions and pulmonary pressures, detailed discussion in the patients about the potential risk to herself and the fetus. While during pregnancy, there should be follow-up evaluation at least 1 per month. close monitoring of the new symptoms or changes in the function classes, serial ECG and echo for the development of new symptoms. In the review of the treatment, the preconception, we should have an effective and safe contraception until pregnancy is desired. Any diseased valve or stenotic valve or damaged valve, incontinent valve should be replaced or repaired just before we get pregnancy. Correction of any abnormalities or anomalies to prior to the conception if the pregnancy poses a significant risk of worsening the clinical stage. Adjust medical conditions to the adverse vital side effects. During pregnancy, minimize medication to the only those about absolutely required. If the symptoms worsen or indicated, consider correction of anomalies or valve repair or replacement during pregnancy. While during labor and delivery, it's advisable to have an invasive monitoring as needed, cesarean section for obstetric considerations and indications, monitoring of the decompensated heart and pulmonary edema and treating accordingly. Postpartum, adjust and optimize the medications, consider abnormalities and valve replacements. In the issue of the predictors of maternal cardiovascular events and the risk, we have a CARPREG study which outlines of 4 parameters, each one have a 1 score. The total score of 0 is a 5% risk, and 1 point have a 27% risk, and more than 1 have a more than 75%. These are the prior cardiac events like heart failure, transient ischemic attack, stroke before pregnancy or arrhythmia. Baseline new heart association classifications, class more than 2 or there is cyanosis. Left-sided heart obstruction like mitral stenosis in marked valve area less than 2 centimeters, aortic valve area is 1.5 square centimeters, and with peak left ventricular outflow to a gradient more than 30 millimeter mercury. Reduce systemic or ventricular function, but ejection fraction is less than 40%. These are predictors of maternal vascular event and risk. There is cardiological indication for cesarean section. Apart from the obstetric causes, patient the cardiological events evidence-based state that patient on oral anticoagulated in the preterm labor should have a cesarean section, no more for the normal vaginal delivery. Patient with Marfan syndrome and in aortic diameter more than 45 millimeter. Patient with acute or chronic aortic dissection, acute intractable heart failure, severe aortic stenosis, and severe mitral stenosis. Cardiac disease with pregnancy. In the term of the cardiac disease, we can classify the cardiac disease into main items: congenital heart disease, like ASD, BSD, patent ductus, or teratology of Fallot, teratology, and the Eisenmenger Syndrome. Valvular heart disease, like mitral stenosis, mitral regurg, aortic stenosis, aortic regurg, and prostatic valves, and myocardial disease as peripartum cardiomyopathy. The congenital heart disease. Patients usually in these categories have corrected or very minimal symptoms, or might be run into the Eisenmenger. So patients with still patent ductus arteriosus and atrial septal defect and ventricular septal defect are common congenital abnormal. There's increased cardiovascular volume during pregnancy. This increase the atrial volume that leads to enlargement of the both atrias with subsequent supraventricular arrhythmias and maybe AF. This form of anomalies, it is a left to the right shunt with increasing the lung plethora, and it is so we have to prevent the air bubble into the yes. Okay. In the action performed or anesthetic considerations in this patient, prevention of air bubble into the intravenous axis, and epidural anesthesia is better using with loss of resistance by saline no more than air. Slow onset of epidural analgesia. oxygen supplement should be given, and antibiotic prophylaxis is given for the victim endocarditis. The tetralogy of Fallot. Fallot tetralogy, there is a minimizing hemodynamics changes that leads to the increased right to left shunt. As we know, there is a fixed shunt and variable shunt. The fixed shunt is the presence of anatomical shunt there, which is the VSD overriding water, something like this. This is obligatory shunt and fixed shunt. And the variable shunt is the changes or balancing between the systemic vascular resistance and pulmonary vascular resistance. While increasing the pulmonary vascular resistance more than the systemic vascular resistance, the blood will shunt right to left shunt more to right to left shunt. While increasing the systemic vascular resistance more than the pulmonary vascular resistance, the blood is enforced to go to the lung with decreasing right to left shunt and improving oxygenation. So it is important to prevent a decrease in systemic vascular resistance. And venous return have to decrease the venous return. And myocardial temperature should be abolished. To my mind, there are some authors they are advising the use of regional anesthesia. For my mind, I'm not using the regional anesthesia in the tetralogy. I use usually general anesthesia. The general induction of agent of this most minimal hemodynamic changes. For example, narcotic and etominate. The regional anesthesia technically can be used with special attention, but for myself, I'm not using it. And I'm not advising my senior staff to use a regional anesthesia, especially spinal anesthesia, and should it be avoided totally. Because when we are talking about the systemic vascular resistance, when they abolish this systemic vascular resistance, the pulmonary vascular resistance is have to increase enough to cause right to the shunt. So slow induction of epidural anesthesia is recommended. I don't recommend it for myself. This is our author's opinion. Eisenmenger syndrome, like the Fallot tetralogy, there is a fixed shunt and there is a variable shunt. The pulmonary hypertension and right to the left shunt produce arterial hypoxemia. The clinical manifestation of both in the Menger or either Fallot tetralogy is the dyspnea, clapping, polycythemia, peripheral edema, and cyanosis. Usually, as in Fallot tetralogy, avoid the decrease in systemic vascular resistance. This is determinant for the Eisenmenger syndrome. The balance between the systemic vascular resistance and the pulmonary vascular resistance is an important in anesthetic management of these patients with Eisenmenger syndrome. General anesthesia for regional anesthesia, I wouldn't like to advise anyone to have a regional anesthesia, but some authors related that usually can be used if there is no contraindication. I usually contraindicate for myself. This is one of the relatively contraindication for the regional anesthesia. Regional anesthesia can be done using epidural dose titration, which are my doubts. Oxygen should be given. Blood loss should be replaced with the colloidal crystalloid component. Invasive monitoring should be done actually with the arterial line and central line, ampicillin and gentamicin as a prophylaxis against infective endocarditis if it helps. Coming to the most common diseases in our environment and our developing countries is a valvular heart disease, the mitral stenosis. Mitral stenosis is responsible for the most morbidity and mortality of the rheumatic heart disease during pregnancy. Normally, the mitral valve area is about 4 to 6 square centimeters. When it is reduced to 3 square centimeters, it is a mild mitral stenosis. 2.5 to 3 is mild mitral stenosis. From 2.5 to 1.5 is a moderate mitral stenosis. Below 1.5 is a severe form of mitral stenosis. Below 1, it is a tight mitral stenosis. The definition of tight mitral stenosis, which is a critical and emergency, and the patient cannot tolerate this type of stenosis, is mitral valve area less than 1, with a pressure gradient across the mitral valve around 20 millimeter mercury, and the patient is dyspneic at rest, or sopnic, I mean. The moderate and severe mitral stenosis is poorly tolerated during pregnancy. The rate of the fetal morbidity including the fetal growth restrictions and premature birth, rises with the severity of mitral stenosis from 14% in the pregnant patients with a mild mitral stenosis to 28% and 33% in pregnant patients with moderate and severe mitral stenosis. The mitral stenosis during pregnancy can be selectively treated by the selective beta blocker. The beta blocker is to increase the diastolic time for the left ventricular filling and improving the cardiac output. The risk is to have to decrease the preload of the left ventricle. Digoxin sometimes we use anticoagulations for the accompanied with AF. One of the most important issues in the management of mitral stenosis is a percutaneous transfemoral mitral valve commissuration. This introduction of the balloon through the femoral artery under local anesthesia going to the mitral valve to mitral commissuration. It's performed after the age after 20 weeks of gestation. It should not be considered in women with NEHA classification, but new heart association classification, class 3 and class 4. Or estimated systolic pressures more than 15 millimeter mercury. The pulmonary artery pressure, I mean. At echocardiography, despite optimal medical treatment, in the absence of contraindication, the patient characteristic is treated. Delivery. For vaginal delivery is considered in the mild mitral stenosis. And in patients with a moderate or severe mitral stenosis, class 1 or class 2, without pulmonary hypertension. But if there is a pulmonary hypertension or severe or symptomatic, severe symptomatic, moderate or severe hypertension, general anesthesia is considered a cesarean section under general anesthesia who have a pulmonary hypertension despite the medical therapy. Anesthetics goal in the mitral stenosis. The anesthetic goal is to maintain the heart rate. The heart rate is a mandatory here because it is allowed if there is tachycardia, there is no time for the cardiac feeling. If there is tachycardia, the severe bradycardia, there is the pressure will come down because of the heart rate is equal to the heart rate by multiplied by the stroke volume is equal to cardiac output. So when global is maintaining the heart rate from 60 to 80 is ideal for the patient with mitral stenosis. You have to venous return. We have to deal with the venous return, and the systemic vascular resistance should be kept. Systemic vascular resistance. Any drop of systemic vascular resistance in that patient will lead to severe hypertension. This is one code of the low fixed cardiac output. Avoid aortic compression by the left chest of the patient, which under the right hip. Aggressive treatment of atrial fibrillation and management, maintaining the sinus rhythm. So we have to prevent pain, good analgesia, narcotic-based analgesia, prevent hypoxia and hypercarbia, of course, and those which is, it is in pulmonary vascular resistance rather than systemic vascular resistance. Again, the authors could use the regional. I can use it in the only mild cases of mitral stenosis. What moderate to severe cases, general anesthesia should be preferred. Epidural is not a good option as no fixed cardiac output. Vasopressor dose of epinephrine because epinephrine is increasing systemic vascular resistance and increases the blood pressure, and we have a flex bradycardia controlling the heart rate. General anesthesia provide stable hemodynamics. Etomediate is one of the best induction agents here, and beta blocker as ismolol. And the dose of load should be administered before induction of anesthesia. The issue of mitral regurg. This is the most common cause of the mitral regurg during pregnancy is either rheumatic or mitral valve prolapse. Usually, it's well tolerated during pregnancy, and the only issue is atrial AF or hypertension that may accompany causing acute symptomatic decompensation. Otherwise, if there is no AF or hypertension accompanying the patient with it. The issue here is the systemic vascular resistance. With increasing the systemic vascular resistance, increasing the regurg. So we have to control the systemic vascular resistance and keep the patient on the tachycardic side. Patient with a left ventricular dysfunction, a symptomatic patient managed consequently without any therapy. Patient with a left ventricular dysfunction or decompensated heart failure may manage by diuretics and digoxin. Hyderezemia by choice in the patient with mitral regurg with severe hypertension or hypertension after reduction. It reduces vasodilatation together with tachycardia, decreasing regurg. Acute mitral regurg may be require intra-aortic balloon pump, which might be an option for the emergency surgery, just before emergency surgery. Delivery, vaginal delivery is preferred in symptomatic patients. Epidural anesthesia here is a good option because it shows second stage and decreasing the swelling. The anesthetic goal with the mitral regurg, it's a state of hypercoagulability and systemic embolization. Epidural anesthesia can be increasing the systemic vascular resistance with engaged prevent pulmonary congestion. Can prevent. Have a vasodilator, decreasing the systemic vascular resistance and prevent pulmonary congestion. Invasive pressure monitoring can be antibiotic prophylaxis recommended. And the main consideration is meaning slight increase in the heart rate to prevent an increase in the systemic vascular resistance and central blood volume. Of course, avoiding the aortocaval compression and hypoxia and something like what causing increase in the pulmonary vascular resistance. The third issue is aortic stenosis. The aortic stenosis is what's called the silent killer of the heart. In women childbearing age, the main cause of aortic stenosis is usually congenital bicuspid aortic valve. 50% of the risk is anomalies of the fetus. We have the baby may have a 50% risk of a similar anomaly. Exercise test is recommended a symptomatic patient before pregnancy, confirming a symptomatic state. Evaluates exercise tolerance and the blood pressure response to this arrhythmia and the need for the intervention. Women with bicuspid aortic valve and aortic diameter should be assessed before and during pregnancy. Cardiac morbidity during the pregnancy is related to the severity, maternal morbidity with the severity of the AIS and symptoms. With asymptomatic mild and moderate aortic stenosis, pregnancy is well tolerated. While in severe aortic stenosis, a sustained pregnancy will at long term remain asymptomatic exercising test and have normal blood pressure during the exercise. I would like to demonstrate that critical or tight aortic stenosis is defined as the valve area is less than 0.5 square centimeter. The pressure gradient across the valve is more than 40 millimeter mercury. This is the critical form of the aortic stenosis. Heart failure occurs in only 10% of the patient with severe aortic stenosis and arrhythmia in 3 to 25%. Women with bicuspid aortic valve have a risk of aortic dissection and dilatation. All symptomatic patient with severe aortic stenosis and asymptomatic patient with impaired left ventricular function, a pathological exercise test should be counseling against pregnancy. We should postpone the pregnancy because mortality and morbidity is little higher, and valvoplasty or surgery should be performed just before pregnancy start. If there is a pregnancy, the pregnancy is not discharged in a symptomatic patient, even with severe aortic stenosis, the left ventricular size and function, as well as the exercise test, are normal and severe left ventricular hypertrophy. Regarding the symptoms, the pre-pregnancy, just before pregnancy, surgery should be considered in patient with ascending aorta more than 50 millimeters. This is a quite dangerous for the patients. In severe aortic stenosis, monthly or bi-monthly, twice a day, cardiac evaluation, including echocardiography, advised to determine symptom status and progression of aortic stenosis and other complications. The medical therapy of the aortic stenosis during pregnancy it consists of restricted activities as indicated for the patient developing signs and symptoms of the heart failure during pregnancy. Diuretics may be administered for congestive symptoms. A beta blocker or non-dihydropyridine calcium channel antagonist should be considered for the rate control of the heart in the AF. If there's contraindications, also may be considered. The delivery in a severe aortic stenosis, particularly the symptoms during the second half of the pregnancy, cesarean delivery should be performed with endotracheal intubation and general anesthesia. No role for the regional anesthesia here, as mitral stenosis. In any stenotic lesion, usually we have the role for regional anesthesia in addition to the cyanotic heart disease. In non-severe aortic stenosis, vaginal delivery is favorable. In non-severe, avoiding the decrease in the peripheral resistance, of course, during the regional anesthesia and analgesia. The anesthetic goes with anesthetic with aortic stenosis. The transvalvular gradient is one of the most important parameters here. Progressive increase during pregnancy. This is due to increased blood volume and decrease in the systemic vascular resistance. So any tachycardia or bradycardia may be determinants for these patients. So we have to maintain the intravascular volume, controlling the heart rate and the venous return, avoid aortic cable compression. Also myocardial compression, maintaining the heart rate as normal condition, because decreasing the heart rate will decrease the cardiac output. Of course, of combination of intermediate and limit opioids with succinylcholine for rapid sequence reduction is the best combination for the general anesthesia. Myocardial ablation for that should be avoided. We can do narcotic-based anesthesia, and the pulmonary artery catheter monitor is controversial, while the CVB monitor is needed for the high level will be advised. Again, the aortic regurg. The issue of the aortic regurg is well related in the pregnancy as mitral regurg. The regurg disease or mitral regurg in general, either mitral valve or aortic, is well related during pregnancy due to the vasodilatations during pregnancy, and this is decreasing the regurg. Once there is increasing the systemic vascular resistance, is increasing in the left ventricular pressure, either increasing the regurg, the mitral or aortic. Dual combination of reduced systemic vascular resistance and shortened diastole will rise in the heart rate, with the rise in the heart rate. In young women, aortic incompetence may be due to the congenital bicuspid valve. Aortic incompetence with the left ventricular dysfunction is usually well tolerated in pregnancy. In symptomatic patients, and that's with this compensated heart, the diuretics and digoxin or hydrolazine may be viewed for after-load reduction. Vaginal delivery is a preferable symptom in symptomatic patients. Epidural anesthesia and shortening the second stage is advisable in mitral regurg. The anesthetic goal in the aortic regurg pathophysiological that occur during the volume overload on the left ventricle, with the hypertrophy and dilatation increase the left ventricular end-stage pressure. And this is decreasing ejection fraction and signs symptom of edema pulmonale or pulmonary edema will develop. So we have to reduce the volume overload for the heart. Minimizing pain is an attempt to prevent the release of catecholamines, increase systemic vascular resistance, and increase the regurg. Of course, tachycardia is much better than the bradycardia. Avoid bradycardia because it can lead to increase its regurg flow. Epidural anesthesia is preferable or recommended for the regurg, mitral regurg, aortic regurg. Induction agent using intermediate and endotracheal intubation using succinylcholine. Remifentanil for analgesia. I'm escaping the prosthetic valve because it is a coagulation issue. We're going to run to the peripartum cardiomyopathy because of the time. Peripartum cardiomyopathy is a pregnancy. It is called a pregnancy-associated cardiomyopathy. It is a rare cause of the heart failure that affects the woman in the pregnancy or even in the puerperium. It is a clinically silent underlying cardiomyopathy exacerbated by the hemodynamic change during pregnancy. It carries a mortality rate with well-known causes. It is about 4 to 10%, up to 80% in undiagnosed cases. More than 50 cases of the occurs in the patient woman aging more than 30 years. It is an idiopathic cardiomyopathy with the following characteristics: development of the heart failure toward the end of the pregnancy or within 5 months following delivery, absence of another identifiable cause of the heart failure, and the left ventricular systolic function is markedly decreased with the ejection fraction is less than 45%. The left ventricle may or may not be dilated. About the risk factor for the peripartum cardiomyopathy is age group. It's more than the 30 years. The African descent and African races are more than. The pregnant with multiple fetus are more liable for the peripartum cardiomyopathy. History of the preeclampsia, eclampsia, postpartum hypertension, maternal cocaine abuse for no smoking are increasing the risk for the cardiomyopathy. And long-term, more than 4 weeks oral tocolytics. This is one of the therapy used in the premature contractions and premature labor. Tocolytic therapy with the beta-adrenergic agonist, such as terbutaline, may precipitate for the peripartum cardiomyopathy, diabetes of selenium, force, and multiple stain. Really, the time of presentation of the cardiomyopathy rarely seen before the 36 weeks of gestation. Usually presented during the first months postpartum. 1/3 of the women presenting prepartum, 1/3, one of them, 21% have a diagnosis of cardiomyopathy in the previous pregnancy. Pregnant women other than cardiac disease, ischemic or valvular or myopathic, may present earlier in the antepartum period, because there are increased hemodynamic burden imposed by the gravity state during the second trimester. Symptoms and signs usually variable, and usually it is I teach my students that it is exaggerated form of normal physiological changes that occur during pregnancy. You see, any pregnant woman have a liver edema, have a dyspnea, have a shortness of breath. She cannot lying down. She has orthopneic, little bit orthopneic. So dyspnea, cough, insomnia, paroxysmal nocturnal dyspnea, and pedal edema and hemoptysis. Here they may be obese. Physical examination of the patient with peripartum cardiomyopathy is tachycardia, elevated jugular venous pressure, displaced apical impulse, and third heart sounds indicating the failure, and murmur of mitral regurg. Sign and symptom of systemic and pulmonary thromboembolism may be present in addition. Here, this is a normal sized heart demonstrating these annulus of the mitral valve and tricuspid valve. Notice during the cardiomyopathy, all the chamber of the heart become increasing the pulmonary muscles stretching and causing the annulus. This causes mitral regurg and severe tricuspid regurg. In the chest X-ray, the heart to cardiothoracic ratio is increased, and there is a left encroaching to the left side more than to the right side, and the other slide shows the congestion, pulmonary congestion in addition. With echocardiography, there is a left ventricular motion, there is a diffuse hypokinesia of the left ventricle, dilated all chamber of the heart, and the left ventricular end and systolic diameter is increasing more than 52 millimeters, which is usually from the 36 to the 52. It's more than the systolic diameter is increased. Okay, there is a severe mitral regurg and tricuspid regurg with reduced ejection fraction. This sometimes may be left ventricular thrombus. Here, there is a dilated form of echo, dilated form of the left echo chambers of the heart. The anesthetic goal for the peripartum cardiomyopathies is variable, but usually the heart failure can occur in the third trimester when the ejection fraction is less than 45, and the systolic diameter is more than 52. This is not right. Avoiding myocardial depressions and attention to the fluid management with the use of diuretics, vasodilators, as well as keeping the heart rate within the normal range. And sinus is the goal management here is the autotransfusion, which is occurring secondary to the uterine contractions or the evolution of the uterus and coming back to this is the most critical time for the cardiomyopathic patients with everything pulmonary edema. So the use of diuretics at that stage and vasodilators if you are going to use the general anesthesia, because there is a different opinion, different schools in management of the cardiomyopathic. One of schools have a general anesthesia with invasive monitoring, arterial lines, and central venous line, narcotics for induction and maintenance of anesthesia, narcotic base, vasodilators, and inotropes sometimes be used like dobutamine or slow dose, mini dose of adrenaline. This is to keep general to carry out the general anesthesia. Other opinion like me, we have to use epidural anesthesia is much better, or some opinion have a continuous spinal anesthesia or continuous epidural anesthesia analgesia, and I prefer this kind of anesthesia for these patients. Please take home message. Stenotic valve disease carrying the high pregnancy risk than the regurgitation. Normal delivery is preferred except in the severe aortic stenosis and mitral stenosis. Of course, oral anticoagulant throughout the pregnancy should be considered when the warfarin dose is less than 5 milligrams because the risk of the embryopathy is low. One of the take-home message, again, I would like to add the cardiovascular collapse during peripartum cardiovascular collapse. We have to think the 4 rules of 4. It is a vasodilatory collapse, or pump collapse, or obstructive collapse, or hypovolemic collapse. So in our issue, we have here in the cardiological point, the second cause is pump collapse. A pump is either because the myopathic, cardiomyopathy, or valve lesions, which might be aortic stenosis, and mitral stenosis is the most common and carrying the care morbidity. If I have a time for case presentation, or that's it?
Dr. Saad Mahdi, do you think we still have time for case presentation from Dr. Fahmy? I think go ahead, Dr. Latif, Prof. Latif, go ahead with the case presentation.
One of the interesting cases coming into our casualties with our patients, females, 23 years old. She had negative GA, the primary gravida, 33 weeks of gestation, was diagnosed as cholestasis with pregnancy versus severe preeclampsia. Presenting for the cesarean section requested by the obstetrician. His lab last meal was 1 hour before. This is not important. The lab investigation have all okay, except that the total bilirubin is 3.2 with direct 1.6, and serum creatinine is 1.3. That's why they are diagnosing her as a cholestasis or pregnancy versus severe preeclampsia, because albumin. Otherwise, the patient was conscious and blood pressure was nearly normal, and the oxygen saturation is 98% with bilateral pitting edema above them. After the patient have consenting for the general anesthesia, for the regional anesthesia, I would like the preoperatively the residents gave the patients RV access into 16 gauge cannula in the cleft right cephalic vein. The patient received spinal anesthesia, total volume of 2.5 ml of bupivacaine, heavy bupivacaine with 225 mic fentanyl in sitting position with 22 gauge. Sorry for this hard large size, 20 because it's a residence at the level of the L4, L5. Then they was giving supine. Data of the patient is very good, but the patient is not satisfied with the regional anesthesia. So the senior assistant lecturers advised him to give a general anesthesia was planned. After pre-oxygenation, the patient was given serpental and fentanyl and dexamethasone, and shortly and give endotracheal tubation with no difficulties noticed, and the patient put in mechanical ventilation. Shortly after intubation, the patient started to drop to 40 to 20 or 40 over 20, the blood pressure, and the heart rate is rapidly increasing. They start to decrease, is 50 to 60. Then atropine is given with no response. CPR started. 1 milligram adrenaline was given. The patient is continuous after 1 cycle. Is continuous circulation after 1 cycle. After a few seconds later, the patient got another attack of the cardiac standstill, and CPR was done, and 1 milligram only adrenaline is given, and the patient cardiac activity again after 1 cycle. The blood gases was okay. There is no except a very mild metabolic acidosis. The fetal was alive. The patient was received about total volume of 1 liter. And urine output was satisfactory. Central venous line injected in the jugular venous pressure was 20 centimeter. I was informed for these patients. They are starting using liver fat infusion, start at the rate of the 59 nanogram per kg. I was notified after they are transfusing the patient to the ICU shortly, and the patient got attack of acute pulmonary edema. I advise them to have an echocardiography for these patients because the patient is coming at the end or showing the picture of suggestive peripartum cardiomyopathy. Would you imagine the ejection fraction of the patient was 28 on vitamin infusion? Severe global hypokinesia, aortic regurg, mitral regurg, RVSB was 35 milligram undilated left atrial. This patient, alhamdulillah, passed safely with no complications, and the patient was transferred again to the cardiological unit for further management. Thank you very much for your audience.
Thank you very much, Prof Latif, for this very interesting lecture that covered actually a very important entity for any obstetric anesthetist, which are the coexisting cardiac diseases. I have actually a quick comment stemming from your case presentation. So it's actually quite scary, you know, like young patient coming to deliver, you would expect a happy story at the end, and then it turns to be severe cardiomyopathy, peripartum cardiomyopathy, undiagnosed, and she was lucky actually to be looked after at an institute like Ain Shams University, and the obstetric unit there, where there is input from all sorts of expertise. I'm trying to imagine what's going to happen to her if her care was offered in a different place. And this actually makes me make a comment, and I'm not sure what's your take about that. What's your view about having proper antenatal care for that group of patients and centralizing their care to be in a tertiary place and making sure that there is some sort of joint plan between obstetrics, anesthetics, and cardiology beforehand in order to avoid surprises? I know we still have rheumatic heart disease in Egypt. We still have patients coming along with untreated congenital heart disease conditions, and they just present while they are already in labor, which is a very difficult situation. But you know, introducing these things still can minimize the surprises that we can see in the labor ward and maternity unit. What's your take on that, Prof Latif?
Actually, you know, Kholi, that the patient we have refers tertiary hospitals. They are draining from the different sites of the Egyptian. With usually, almost they have no antenatal care. Surprisingly, when I had the obstetric anesthesia department, 2 years before, we have a 37 out of 11,000 cases cardiomyopathic patients. Would you imagine? Every month we have 2 or 3 cases for cardiomyopathic patients, which is not diagnosed. I order my colleagues, and we are collecting to have an program on the echo, on the sonar, to a program to just see the cardiac contractility for rough.
Like bedside echo for those patients.
As bedside echo, not
point of care.
Not of course for the but just monitoring for us that the patient is in left ventricular dysfunction. As you know, of course, the cooperation between the obstetrics and anesthesia and is there, but the patient compliance is not there.
Yeah, unfortunately. Yeah.
Unfortunately, because they are it's not draining from the rural area, and the patient is not antenatal. There is no antenatal care, proper antenatal care.
So just food for thought. Would a campaign in the media help with that, just to increase the awareness? Just food for thought. You know, like bilharziasis in the past, very simple, few minutes thing on the TV played actually wonders with combating bilharziasis in Egypt. So would something like that campaigning, would it help with increasing awareness of public about antenatal care in order to avoid such kind of surprises and high mortality in women and children, which is disastrous in any developed country. That's really disastrous.
Yes, I agree with you totally.
Yeah.
But we have no plan, and we are a doctors, not a politician. You know.
Of course, yeah, I know. So a couple of questions coming from the audience. The first question is from Dr. Hilal Siddiqui. His question is not very clear to me, but I'm going to ask it. Epidural anesthesia, what level and how high level of the block is recommended? I'm not sure whether this is in relation to cardiac or in general.
Yes, I have to know what work. Usually for normal vaginal delivery or cesarean section, for normal vaginal delivery, T10 is adequately enough. For the normal, not cardiac patients, T10 is quite enough. But for cesarean section, I think it is for the T4 to T6, 4 to T6 is quite enough for it.
Right, the question actually is not quite clear. The other question is from Dr. Muhammad Wahba. He's saying a patient with stent, I wonder actually ischemic heart disease, and she got pregnant and on anticoagulant, and she's coming for cesarean section, and she's requesting regional block. What's the perioperative recommendation?
According to the what type of anticoagulation she has run on, antiplatelets or anticoagulant or heparin?
Probably I'm assuming she will be on some sort of dual antiplatelets, because most stents are drug eloting at the moment.
According, if there is antiplatelets, it's like aspirin in regular dose, no contraindications. I can give in now recommendations if your patient gave 81 milligram aspirin, astaxanthin, no more. You can go in. If there is taken an antiplatelets, we have to half-life of 4 to 7 days just before the spinal block to be insured. But Clexane, it is a half-life of the drug. When the drug is used as a prophylaxis, only 12 hours, or the curative, 1 to 1.5 milligram per kg, we can stand for 24 hours.
I have another question as well, Prof Latif, please, and I think we'll conclude the session afterwards. There is another question from Dr. Higazi, but it's not about cardiac disease and anesthesia. It's about using magnesium sulfate. So my question is about your view on general anesthesia. So I noticed that you're in favor of using GA for severe cardiac disease, and you're in favor of using a combination of etomidate and succinyl for rapid sequence induction. I'm personally not an obstetric anesthetist, and I don't have quite good experience in etomidate. We all know the risk of adrenal insufficiency after using it, but what's your take or comment on that, please?
You see, we have not, this is a recommendation, author's recommendation, but for ourselves, we are using those sleeping dose of Tribentel because we haven't etomidate in Egypt, you know, of course. And instead, if there is a patient, we are balancing between the ketamine and Tribentel, sleeping dose of that, and to maintaining the blood pressure. What? I can't down written in the lectures that we're using dose of that. You understand me?
Yeah, of course, of course. I mean, you're talking from personal experience.
Yeah. But actually, I have no experience with etomidate at all.
Right. I personally used it once or twice in ICU, and the consequences were not good, but the patient was really sick. So I think it's very, very difficult to comment on that. My last question actually is about, well, it's part of this question about offering GA. So I worked in St. Mary's Hospital, which is one of the biggest obstetric units, but not as big as Ain Shams University in Manchester here. And they always run like joint plan for cardiac patients presenting for delivery. And they opt for using combined spinal epidural, so they use very low volume spinal. And then they start slowly topping up the epidural to make sure that they catch up during cesarean section with appropriate level for the section. Knowing all the inherent risk of GA in obstetric patients. So what's again your take on that, Prof Latif, because of the airway problems, etc., with GA?
See, Dr. Khoury, I don't recommending the use of the general anesthesia in general. In cardiac selected cardiac patients, patient with Eisenmenger syndrome, patient with palatotrology, patient with a severe aortic stenosis, severe mitral stenosis, no place for the general anesthesia, for the regional anesthesia. For me, it is one of the low fixed cardiac output. whenever we have a lost systemic vascular resistance, we can lose the patients. We lost the patient in the aortic stenosis or mitral stenosis. This is a criteria. You know that it's tight mitral stenosis and tight aortic stenosis. Otherwise, in mild mitral stenosis, I'm using spinal anesthesia as small dose. In aortic regurg and tricuspid, aortic regurg and mitral regurg, I usually give the regional anesthesia, epidural anesthesia. But wherever there is an issue of the systemic vascular resistance, any drop of systemic vascular resistance, which might decompensate, because in cyanotic heart disease, there's a balance. This is the variable chunk I have to play with. The balance between systemic vascular resistance and the pulmonary vascular resistance. When with the spinal anesthesia or regional anesthesia, there is a drop in systemic vascular resistance and increasing the pulmonary, increasing the chance. But in aortic stenosis and mitral stenosis lesions, the main factors for maintaining the blood pressure is the peripheral resistance. As you know, blood pressure equals the stroke volume, cardiac output, peripheral resistance, right? When I'm dropping the peripheral resistance or systemic vascular resistance, there is marked hypotension. I'm not relying on the drugs to increase in phenylephrine. We have no variability of the drug like phenylephrines, Avofeds, ready to use to elevate systemic vascular resistance again. Why? I have to use to play with the general anesthesia, the prophylaxis against emesis, rapid sequence inductions, and high dose of narcotics until the neonatologist that we're giving narcotics just before the baby is coming, and actually giving for these patients, more than 200 mic or 300 mic fentanyl. The baby is coming crying very well. By the way,
right.
It's not, we have to tell them. But the cardiomyopathic patients, with the cardiomyopathy, my experience is dural anesthesia is much better than the general anesthesia.
If we rephrase this, so knowing the pathology, tailoring your anesthetics according to this pathology, and working in the best interest of patients. Is that fair take-home message, Prof Latif?
Yes.
Brilliant. There is one last question about use of TEE in the management of cardiac patient in obstetric. I think that's too invasive to my own understanding, but what's your comment on that?
TEE, in obstetric usually we have regional anesthesia. There is no for TEE. You see, we have to sedate the patients, but whenever there is complicated cases like cardiomyopathic patients or severe aortic stenosis, the role of TEE for the volume adjustment is very nice, of course.
Right. Yeah. Right. Thank you very much, Dr. Latif. Really appreciate this very interesting lecture. Thank you for your time. Thank you for this very nice